mentioned that immune stimulating could have a negative effect. Did you mean immune modulating, or can you expand a little bit on what you meant by this? Immune stimulation might have a negative effect on mortality.
Yeah. If you're in a campaign like this, in a situation with a high mortality, if you had used, we did not do that, but if you had used DTP vaccine, or maybe introduced hepatitis B vaccine, my prediction would be that you had increased female mortality. I showed you the data which were of IPV inactivated polio vaccine, that those who had IPV as the last vaccine, they had higher mortality. And that's specifically for the girls. If you add vitamin A is considered the golden bullet in pediatrics in developing countries, and it's assumed to reduce mortality to 25 to 30%. All those studies were made in a time where the vaccination coverage was much lower than it is now. Then it was made policy to do it together with vaccine. No study has examined that. There's no trial which examined vitamin A provided together with the vaccine. We reanalyzed one of the first trials, the only one from Africa, which showed a positive result. It was published last year. They had actually collected the data on vaccination, but they had not analyzed it. What came out of that analysis was that they had reported 90% reduction in mortality in the paper in Lancet. All of that effect was among children who had no vaccines. So the whole beneficial effect was among children who did not have a vaccination card. Among the children with a vaccination card, vitamin A reduced mortality 25% for boys, but it increased it 20% for girls.
What?
It increased it 20% for girls.
Increased mortality.
No.
Increased mortality.
Is there any indication what the reason of that is? Is there an idea of what the reason of the increasing of the mortality of the girls in comparison with
Boys and girls must have different immune systems. No one's looking at this.
Exactly.
No one is looking at this. We have done the experiment in mice. If you immunize mice with live vaccines, you get a Th1 response. But if you immunize the mice with a Th2, with a dead vaccine, an inactivated vaccine, you get a Th2 response. And that works for sort of RSV, measles, TB, influenza. It's the same pattern. And when the mice are challenged, if you have a Th1 profile, you can handle the infection. You cannot if you have a Th2 profile. And for some reason, girls are more Th2 prone than boys. So you may, in fact, be stimulating the warm side of the immune system. I can show you some data here, but here recently, I'm going to submit a paper next week about a cohort of girls, and there are low birth weight children, and we've documented very carefully their vaccination status. DTP within that group increased female mortality 6-fold. You had 6-fold higher mortality for girls who had received DTP early. I showed you, I don't know, some of you may know, but 20 years ago there was introduced a new measles vaccine by WHO, which was called high-titer measles vaccine. I reported from Guinea-Bissau and from Senegal that vaccine was associated with 2 times higher mortality. When this, for girls, but only for girls, when that was confirmed on Haiti and in Sudan, it was withdrawn by WHO, but there were no decision to follow up on this. Everyone thought there must have been some problem with the vaccine, so they went back and gave all the money to the virologists so they can develop a new vaccine. There's no new vaccine as yet. We showed later that the whole effect of this new vaccine was that you had vaccinated earlier, and therefore the children had received DTP after the measles vaccine. And that's very bad news. So the whole excess female mortality was due to the girls who had received an inactivated vaccine after the measles vaccine. And I submit to you that that's happening every day in Africa because it's the donor policy to increase the coverage for DTP-free. So there are teams out there which are increasing vaccination coverage with DTP because that's what the donors are measuring. So, and when you then add vitamin A on top of that, you are getting increased mortality. You're also doing it if you give vitamin A at birth, you are increasing female mortality. We have done 2 studies in Guinea-Bissau. If you give vitamin A at birth, that as some people want to do, if you do that, you are reducing male mortality by 20%, but you're increasing female mortality with 40%.
You have one, and I have seen one up here. And
Yeah, I wanted to follow up on this, Mayor.
yeah, okay.
And I remember you next to
What would be your recommendations then in how to vaccinate?
My recommendation would be to be sure that you get BCG at birth. We have done a randomized trial at BCG at birth in low birth weight children. You can do it in low birth weight children because they normally do not get BCG. That reduced neonatal mortality with 45. That's immune stimulation. It has nothing to do with TB. So you reduce the neonatal mortality with 45. That would be a very important intervention in a conflict situation where you're not managing the hospital to get the newborns vaccinated with BCG. That would be one good thing. I would vaccinate the boys with DTP. Boys seems to be much less sort of labile in their immune system. So I would give the boys a DTP, and I would give everyone measles vaccine at 4 months and at 9 months. That would be my optimal vaccination program. I would not vaccinate the girl with DTP. I think the damaging effect of DTP is worse than the risk of getting whooping cough. But that, no, those
So
things
you
would
have-
have to be
yeah.
shown in studies.
You mentioned several times the problem of the conflict between the project and the donors over the issue of targeting assistance only for the
Yeah.
displaced. This is a classical problem.
Mm.
I was just wondering, did you have any success in convincing, or did you give up?
Yeah, we just did it. You know,
Yeah.
we-
You never convinced anybody, you just did
No, I probably didn't convince the donors, but since we were implementing the policy, we did it the way we wanted to do. What happened in Guinea-Bissau was we had a national humanitarian aid committee, which sort of with representation from both sides, both the government and the rebel side, and the NGOs and the churches, and then my project, which was sort of the health project involved, and we decided. So the donors, to some extent, had to follow the policy for the national committee, sort of which combined the two sides of the conflict. We had several other conflicts about this issue of buying rice. The argument from the World Food Programme for not buying rice locally was that their regulation told them that to buy rice locally, it should have been produced locally. This was imported rice, which was imported for the trade. There was no one buying it because people don't have any money. So we could actually buy it with the donor money we had access to. But the World Food Programme would not allow that according to the regulation. The second thing was that it wasn't fumigated, and they wouldn't distribute anything which wasn't fumigated. I said, no, to hell, these people are going to eat this very rapidly. It's not a question of long-term maintenance. And thirdly was the issue of the logo. What happened then was that I got EU money to buy the rice locally, and then World Food Programme eventually had to follow suit, and they also bought rice.